Yeah. Hello, good evening, namaskar. Myself Dr. Dinesh Yadav, and we are live at Unacademy YouTube channel. So, in this NEET PG YouTube channel, today we are going to discuss the INI-CET number 2020 pharmacology questions. So, these are recall based questions. Definitely, the language maybe it was different in your main exam, but because we have the questions basis on the recall, so we will try to explain the concept that how to attempt these type of questions and why these are important. Because in NEET PG exam many topics, I would not say that exactly the question, but the topics they repeat from the INI-CET, or you can say in previously it was AIMS. So we should know about this. Yeah, Mr. Khan, good evening. So let's start with this these questions. Before starting, just a brief introduction about myself. I'm your NEET PG educator and I'm author as well as a clinician. This is my code, guys. Pharma UA. UA is Unacademy. So Pharma Unacademy. So Pharma UA. It is the code to basically get the subscription. You will get the 10% off. Also, to log in my special classes, you need to open the special class. For that also you can apply this code. So in Unacademy free plan, now you have to unlock it, and for unlocking you can use my code Pharma UA, right? So in this month we have these special classes. So these are the links given for these special classes. Two classes already happened. So every Monday we are having these class at 9 p.m. So these are very conceptual classes. All the concepts in pharmacology we are discussing. So you can directly tap on these links to watch the special class. Yeah, hello, Mr. Terror Gaming. So let's start with the question. The first question was drug that, so you can see in AIMS or INI-CET or in NEET PG or in FMG, pharmacology weightage is around 15 to 20 depending on the questions. Mostly 15 questions are definitely there, but if you will see the interrelated questions with the other subjects which are called as integrated questions nowadays, so these in this integration manner you will see around 20 questions mostly you will get in the in this subject pharmacology. So the first question is drug that reduce the mortality in COVID-19 patients. In COVID-19 patient, which drug reduce the mortality? So guys, in reducing the mortality as per the latest studies by the WHO, even by the other especially the European journals, so they have specified that out of these drugs only the steroid, and the steroid is dexamethasone. The steroid which is dexamethasone, it have basically decreased the mortality. So it decreased the mortality as well as it decreased the days on the ventilator. So basically dexamethasone role in COVID patient is basically to decrease the or to inhibit the cytokine release. So when the patient is having cytokine release syndrome, in cytokine release, so cytokine release syndrome that happens in this COVID-19, and this cytokine release syndrome leads to ultimately MODS, multi-organ dysfunction syndrome, and that is the important cause of mortality. So that is specifically reduced by the dexamethasone. We use the LMW heparin like enoxaparin if the patient D-dimer is high. So there is a role of D-dimer. You should go for D-dimer. If D-dimer is raised, then we use it. Favipiravir is only for mild to moderate patient. It can be used in mild to moderate patient, not to be used in severe. It is antiviral. Remdesivir is also a good drug for moderate to severe cases, but till date even the WHO has said that remdesivir cannot decrease the mortality. So right, so in this the best answer would be dexamethasone. This question they have asked in the FMG exam, this question they have asked in this INI-CET, and most probably this type of question, one question from COVID, they will ask in the NEET PG also. So be prepared for that. One more question was there from the COVID infection only, that in severe COVID infection, if the COVID infection is severe, least effective drug is. So always when you go for the exam, suppose you will go for NEET PG, then before NEET PG you have to read the latest guideline in the COVID treatment, because the guidelines are changing with the time. New drugs are coming, new things are coming, right? So whatever the latest guideline, you just go through those guidelines. So as per the recent guidelines in severe COVID-19 infection, which drug is least effective? So severe COVID infection, least effective drug. So as I already told you that in severe infection like cytokine release, we can use the dexamethasone. If there is high D dimer, then we can use the heparin, low molecular weight heparin, anticoagulants. There is role of anticoagulants. Remdesivir also I told you we can use in moderate to severe. But favipiravir is not having any role in severe. It is not effective in severe cases. It is approved for mild to moderate cases only, right? So that we have already told you. So favipiravir is the drug that is used for mild to moderate, not for severe. Mild to moderate cases only it is approved. And remember, these antivirals are mainly effective when you give the antiviral just when the basically infection starts. So initial days only if you will start, then they are having very good role, right? So that is about the this favipiravir. Then next question, what is false statement? What is false statement regarding drugs used in gout? Remember guys, there are two very important questions in NCETs. If I say NCETs topic, in NCETs, one very important is drugs for gout, the second very important is drugs for migraine. So always go through these two topics, drugs for gout and drugs for migraine, and one aspirin. Always read these drugs in before every exam. So false statement regarding drugs used in gout. So gouty arthritis, diclofenac is more concentration in joints. Yes, diclofenac is having more concentration in bones, joints and muscles. In these it is having high concentration, so its concentration is high in these areas. So definitely for bony pain, fracture pain, joint pain, muscular pain, you can use the diclofenac. Then indomethacin acts via multiple pathways. Yes, indomethacin, that is also NSAID, and that is acting via multiple pathway. It is inhibiting the COX enzyme. Definitely it is COX inhibitor. It is also inhibiting the phospholipase A2. So by inhibiting the phospholipase A2, it can decrease the prostaglandins production. And it is also having other anti-inflammatory activity, like indomethacin can decrease the neutrophils migration. So it can also inhibit the migration of neutrophils towards the inflamed joint, right? So it can also inhibit the cells migration towards the joint. So that is also the role of indomethacin. So that is also true. Then so this one is true, this one is true. Aspirin not used as it decreases the uric acid secretion. So that is true, because aspirin, it is having the secretion through the urate. So uric acid transport, right? So urate one is there in the kidney. So it is secreted through same. So uric acid and aspirin secreted through same transport. So it is not used because it decreased the uric acid secretion. That is true, because it increased the uric acid level in the body, and because of that it is not used in the gout patients. So aspirin should not be used in the gout patients, even it is anti-inflammatory. Aspirin used in gout as it is having anti-inflammatory activity? No guys, aspirin is not used in the gout patient. Out of the NSAIDs, indomethacin is best for the acute purpose. Aspirin is not used because it is inhibiting the uric acid excretion. Remember, indomethacin is best if NSAIDs are not effective. If refractory cases, then we use the colchicine. And in chronic patients, allopurinol and febuxostat. Overall, allopurinol is the best drug to decrease the uric acid synthesis, right? Yes. Next question, guys. Neurocysticercosis. Neurocysticercosis, parasite, helminth in the brain, brain cysticercosis. So it is one of the cestode. It is one of the cestode in the brain. Patient was on anti-epileptic drug. So this was basically a case. Exact language is not known, but the case was given which was diagnosed as neurocysticercosis. So radiology integration was there. Patient is taking the anti-epileptic. What is true about the further management? So we use the anti-epileptic, especially like carbamazepine like drugs are very effective. So the purpose is because the patient may have the seizures, pressure symptoms could be there, seizures could be there, so anti-epileptic may be given. But the other important thing is you have to see the CT scan if there is already calcified cyst. In calcified cyst, remember the parasite is not live, so then no need the anti-parasitic drug. But if all the cysts are not calcified, then we have to give the anti-parasitic also. So most of the students were saying that the cysts were there and not all the cysts were calcified. So we have to use the steroid as well as anti-parasitic both. Already the anti-epileptics are given, so you can only continue the anti-epileptic. That is not true, because we have to give the other drugs. So we have to give the anti-parasitic and we have to give the steroid. Why we use the steroids? Steroids are used like dexamethasone, these type of drugs, prednisolone can be used because steroids are used to decrease the edema. So the role of steroid is to decrease the cerebral edema. Decrease the cerebral edema. Right? Now the thing is whether we need to give the steroid first or anti-parasitic first. See, if we use the anti-parasitic, we are using the albendazole, that is overall drug of choice. Albendazole is the drug of choice for this neurocysticercosis. But if the number of cysts is high, then we can use the albendazole plus praziquantel. Both these drugs can be used if the number of cysts is high. So as per the latest guidelines, the number of cysts is important. If more than 2, then we have to give the albendazole praziquantel. So we use the anti-parasitic, these drugs. When we use the anti-parasitic drug, there will be allergic response. There will be allergic response because these are targeting the parasite and the parasite will be killed, and then the factors which are released from the parasite, they will cause the allergic response. To control that allergic response, we need the anti-allergic, especially like steroids. So that's why before giving anti-parasitic, we should give the steroids. So steroids should be given 1 day before than the anti-parasitic, because steroids are mainly used to decrease the cerebral edema, but they can also help in inhibiting the allergic response by the anti-parasitic drug, which is happening because of the killing the parasite, right? So steroid and anti-parasitic both will be required. If all the calcified cysts, then I would say we should give the anti-epileptic and steroid without anti-parasitic, right? But because no clear cut, and out of these two options, definitely one will be better option. So steroid should be followed by the anti-parasitic drug, right? So yes. Next question, guys. The least sexual side effects seen with which antidepressant drug? So guys, antidepressant mechanism and side effects are very important. So imipramine, which is tricyclic antidepressant, fluoxetine is SSRI, mirtazapine, that is noradrenaline serotonin specific antidepressants, and venlafaxine, it is SNRI, serotonergic noradrenergic reuptake inhibitor. So these all are antidepressant. Imipramine, fluoxetine, venlafaxine, these drugs are causing sexual side effects. These drugs are causing sexual side effect. You can say these are decreasing the libido. These are decreasing the libido. That's why I told you in my classes that because these drugs are decreasing the libido, excitement, so they are delaying the ejaculation, and because of that, these drugs can be used for premature ejaculation patient, like especially this SSRI, and in SSRI especially this paroxetine we use for premature ejaculation. The reason is because it decreases the libido, excitement. So out of these, maximum risk seen with the SSRI, but we have with the TCAs, SNRIs also. Mirtazapine is the drug which does not have the sexual side effect, or you can say it is having the least sexual side effect. The reason for sexual side effect is because of the serotonin receptor 5-HT2. So because of the 5-HT2 receptor, so these drugs, why increasing the serotonin? Because they increase the serotonin. By increasing the serotonin, these drugs can stimulate the 5-HT2 receptor, and that can decrease the libido. Mirtazapine is basically not inhibiting the 5-HT2, it is 5-HT2 block, not stimulating, it is inhibiting the 5-HT2. So by inhibiting the 5-HT2, it is not causing the sexual side effect. So mirtazapine is not causing the sexual side effect. That is atypical antidepressant. So trazodone, mineserine, mirtazapine, these are not causing this sexual side effect. So mainly with the SSRIs, these sexual side effects will be there. Next is, out of the following, which is acting via promoting the bone formation. So acts via promoting the bone formation. So guys, raloxifene, which is bisphosphonate, calcitonin, alendronate, teriparatide. Now remember, the drugs which promote the bone formation, or you can say stimulating the osteoblast, so by name you can see it is parathyroid hormone. So it is the recombinant parathyroid hormone. It is the active fragment of recombinant parathyroid hormone that is used intermittently, not daily doses, intermittent use of this parathyroid hormone that can increase the bone formation, stimulate the bone formation. So this is the important drug for this teriparatide. One monoclonal antibody is also there, that is romosozumab. So romosozumab can also be used for this purpose, right? That is also having this purpose by inhibiting the sclerostin. So this is important question they have asked in the previous exam, sclerostin inhibitor, that is also helping in bone formation. Raloxifene, calcitonin, alendronate, right? Sorry, this is bisphosphonate, and this raloxifene, which is SCRM, right? So these drugs are inhibiting the osteoclast, or you can say bone resorption, right? And strontium renoliate, that is having both action. So inhibiting the osteoclast as well as stimulating the osteoblast. So bone resorption is inhibited and bone formation is there. So that is both action. So yes, so out of this, teriparatide acting via bone formation. Next question, guys. Yes, the patient was admitted in hospital for depression. Was started on amitriptyline. Amitriptyline is one of the tricyclic antidepressant. Mostly we don't start with amitriptyline unless and until the patient is having severe, because SSRIs are overall best. Patient stayed in the hospital for 4 weeks. So this patient was staying in the hospital for 4 weeks and the depression was controlled. So what is the main concern after discharging? After discharge, right, when you want to discharge the patient, what is the main concern? So guys, with tricyclic antidepressant, sedation is there. With tricyclic antidepressant, arrhythmias is there. With tricyclic antidepressant, we need to do the therapeutic drug monitoring. And with tricyclic antidepressant, suicidal risks are also there. With all antidepressant, there is risk of suicide. Why? Because due to antidepressant, the patient will have the basically more energy, because in major depression, the patient is having lack of energy. And when the patient think of suicide, the patient commit the suicide. So the suicidal risks are there with all the antidepressants, especially SSRIs, TCAs, SNRIs, they have the risk. But now see, if you talk about the sedative, then all the tricyclic antidepressants like amitriptyline, they have the sedative nature, but we are not concerned about that, because mostly the patient having the sedation, and we used to counsel the patient that you will have more sedation, because of that you need not to do the work of like driving and all. So that is fine. ECG monitoring for arrhythmia is not continuously required, because already the patient was in hospital for 4 weeks, and during that time we have already adjusted the dose by using the therapeutic drug monitoring. So TDM is required for initial weeks only. When the amitriptyline dose was adjusted, now there is no need of TDM after 4 weeks. And same arrhythmia risk is there when there is this amitriptyline toxicity. So initially only we need to do the ECG monitoring. If already the dose has been adjusted, no need of ECG monitoring after discharge. So in all these antidepressant after discharge, mostly the patient comes with the suicide attempt. So suicidal risk is there. So we always advise the attendant to not to leave the patient alone. Same happens with the SSRI also. We ask not to leave the patient alone. So guys, it is D, not B, right? But remember, we can have the arrhythmia risk with the amitriptyline, but that is initially only because after we have adjusted the dose, now there is no risk. Then which of the following statement is true regarding use of these drugs? Right? Which statement is true regarding use of these drugs? So Indomethacin used in headache, Aspirin in peptic ulcer, Pethidine in biliary colic, and Morphine in pulmonary edema. So guys, Indomethacin in headache, we don't use Indomethacin in headache because Indomethacin side effect is headache. Aspirin in peptic ulcer, we don't use aspirin in peptic ulcer because of the risk of gastric erosion. Pethidine in biliary colic, we don't use, we can use Pethidine ideally, but because it is same morphine group of drugs, so we don't prefer the opioid in biliary colic. Morphine used in pulmonary edema, yes, morphine. The exact language of this question is again confusing. Some are saying the different language, but if I say this type of language, then I can say morphine in pulmonary edema definitely, because morphine causing systemic vasodilation, and because of that it can shift the fluid from pulmonary circulation to systemic circulation and it can relieve the edema. That is also called as cardiac asthma. So morphine used in cardiac asthma patients, right? But practically I can say Pethidine can be used in biliary colic. Indomethacin can also be used in some kind of headache, but ideally it should be avoided. The next question is anti-migraine drug. Anti-migraine drug causing angina due to which mechanism? So anti-migraine drugs causing the angina. In angina, that means coronary vasoconstriction. Coronary vasoconstriction, then only the patient can have the angina precipitation. So serotonin agonist or serotonin antagonist both are contradictory. Release the nitric oxide, so vasodilation. Inactivating the calcium channel, vasodilation. 5-HT2 antagonist, vasodilation. 5-HT agonist can cause the vasoconstriction. So you can see out of these mechanism only vasoconstriction seen with the first one. And I hope you are aware that triptans are acting through serotonin. The ergot compounds are acting through serotonin. So these compounds can cause the risk of coronary vasoconstriction. Angina MI can be precipitated by the 5-HTT or serotonin agonist drug. Right? So that is A. I hope you all are aware. All of the following drugs may worsen. Drugs may worsen the myasthenia gravis except. So which drug may worsen the myasthenia gravis? Phenytoin, which is a sodium channel blocker. So Digene, in this we have the aluminium and magnesium. Magnesium, it can cause the calcium inhibition, calcium channel inhibition. Lidocaine, sodium channel inhibition. So these drugs like phenytoin, Digene, lidocaine, these drugs may worsen because they have the effect on the neuromuscular system. But meropenem is the antibiotic which is carbapenem. It does not have any effect in the neuromuscular system. The antibiotics which have the effect in the neuromuscular junction, that is aminoglycosides mainly. Some fluoroquinolones and some macrolides, but mainly it is the aminoglycosides, right? But no role of meropenem in this. But other like phenytoin, Digene, lidocaine, all these can worsen the myasthenia gravis, right? So the answer would be D, meropenem. So remember the antibiotics, aminoglycosides, fluoroquinolones and macrolides, they can cause the problem. The next is the patient prescribed high dose of penicillin with gentamicin. So the patient was prescribed penicillin and gentamicin, which is true. So what we should do? TDM should be done for penicillin. For penicillin, no TDM is required. Therapeutic drug monitoring, very important question in general pharmac. Every year the question is coming. So remember the condition where the therapeutic drug monitoring required. TDM should be done for gentamicin. Yes, in aminoglycosides, we need to do the therapeutic drug monitoring. TDM should be done for penicillin and gentamicin, both no. TDM not required. So TDM is required. So high dose penicillin and gentamicin, so this is mostly used for the Pseudomonas infection. And when we use these gentamicin like drugs for Pseudomonas, we comparatively in these cases mostly it is seen in the gentamicin like drugs when we are used for the nephrotoxic patients, in the kidney patient, the therapeutic drug monitoring required, right? Pseudomonas infection commonly seen in these patients. So then TDM should be done only for gentamicin. No need of TDM for penicillin. In penicillin, there is a risk of anaphylaxis reaction. In penicillin, there is a risk of allergic reactions, but that is not avoided by therapeutic drug monitoring, because these are allergic responses, type B adverse reaction. These are unpredictable, so you can't predict by using this. So yes, TDM should be done for that purpose. 15-year-old female complaints of cough, cold, sore throat. So we have given the anti-cold as well as we have given the antibiotic. After these patients develop these symptoms, what is the responsible? So you can see the maculopapular lesion. So maculopapular lesions or rash were seen. So the question is again confusing, because most of are saying the antibiotic was given. So out of these antibiotic is only one amoxicillin, right? But if you will see in other way also, then corticosteroids are used for the treatment. Fexofenadine is also anti-allergic, antihistaminic, so that can also suppress the rash. Salbutamol and amoxicillin, out of these amoxicillin causing the rash. So in any way amoxicillin would be the answer. So that is very simple question. In absence seizure, which drugs are effective? Absence seizure. So in absence seizure, the problem start in the thalamus. I used to say in the class that there is problem with the calcium channels, and then the signal start but not reaching up to the cortex. So in cortex we have the sodium channel, but the signal not reaching up to that. So the drugs which would be effective will be the calcium channel blocker only. These drugs will not be effective. So out of these, which is the calcium channel blocker? Valproate having the calcium channel blocker, ethosuximide is calcium channel blocker. Carbamazepine is a sodium channel blocker, not having effect on calcium channel, so not effective. Gabapentin, that is used, GABA analog, that is used for partial seizure only. In partial seizure, not for these seizures, generalized seizures. So out of these 2 and 3 only. Out of these 2 and 3 only. So valproate and ethosuximide will be used for this. Overall, for typical absence seizure we use the ethosuximide, and for atypical absence seizure we use the valproate, or in children specifically the ethosuximide is very safe, right? So ethosuximide is overall very good drug for typical absence seizures, right? Yes guys. Next, a polytrauma patient having pelvic fracture and head injury was given morphine to subside pain. Morphine is given, that is an analgesic drug, opioid analgesic, to subside the pain. After giving morphine, the patient is having respiratory difficulty. So now this patient is having respiratory difficulty. So as you are aware, morphine can cause the respiratory depression. What is the reason for that? So it is because of the CNS lesion, it is because of the pelvic fracture, it is because of the morphine addiction, or it is because of the respiratory depression due to CO2 retention. So if it is due to CNS lesion, then why it is after morphine? Because the problem occurred after morphine, so it is not because of this, not pelvic feature, not because of morphine addiction. Because morphine causing the respiratory depression, it increased the carbon dioxide retention, and due to which the patient is having respiratory difficulty, right? So in head injury patient, that is why we don't use morphine, because morphine causing CO2 retention, it can also raise the intracranial pressure, right? So because of that we should avoid the morphine, we should not use the morphine. The next question from the rationality, the codeine and dextromethorphan. Codeine is opioid antitussive, and dextromethorphan, it is the derivatives of opioid, not exactly opioid, but it is also having the antitussive. So both are having the antitussive property. What is the true regarding this combination? So if both are antitussive, then why we should use both these drugs in combination? We should give the other drugs if we are using the combination. So why the same group of drug? Either we use the codeine or dextromethorphan. We don't use both these drugs together. It is irrational combination, so it should not be used. It can be used to treat cough effectively. No, both these drugs should not be used together. Right? Higher risk of addiction. So no, there is no higher risk of addiction. Codeine is having high risk of addiction, not the combination. Used as it has the different mechanism of action, no. Right? So this combination is irrational, so it should not be used. Very simple. We can use codeine with other like anti-cold and salbutamol like drugs, but why to give both antitussives together? So antitussive, both are antitussive. We should not use them together. This is total irrationality. It is just like bromhexine plus ambroxol used together. No, they should not be used. Which of the following drug does not cause dilated pupil? Means mydriasis. Cocaine is sympathomimetic. Pilocarpine is parasympathomimetic. Phenylephrine is sympathomimetic, alpha agonist. Amphetamine is also having sympathomimetic, indirectly sympathomimetic activity. So you can see pilocarpine, which is causing meiosis, not mydriasis. Rest of the drugs are causing mydriasis. So very simple question. Cocaine, beta Pankaj, cocaine is sympathomimetic, so it will cause the mydriasis. It is indirectly acting. Then the diagram of MDI meterdose inhaler image was given. So most common drawback of MDI. So why we don't use MDI and what is the risk of MDI in some patients? So it does not provide the instant relief. It can provide the instant relief, so it can be used for emergency purpose. Portability, there is no issue with the portability. Drugs deposited in the oropharynx, yes. This is one of the problems seen with the MDI. That's why we advise for gargling. That's why we advise for gargling, and by gargling you can advise gargling immediately after using MDI. By that you can avoid two things. One is you can avoid the local effect if there is any problem with the drug, and you can also inhibit the systemic absorption of the drug. So you can also avoid the systemic side effect. Mostly the drug particles which are deposited in the oropharynx are the particles which are basically large in size, like mostly more than 5 microgram, right? Micron. So we should advise for gargling. Must be administered in the hospital setting? No, patient can use it anywhere, right? So portability is not an issue. It can provide the instant relief. So the oropharynx deposition is the main problem seen with the MDI. And to avoid that, we can also use the spacer. Spacer can be used for that. True about disulfiram. I hope you all are aware disulfiram is the antabuse. So it is used in alcoholic patient as antabuse. Inhibiting the alcohol dehydrogenase? No, it is inhibiting the aldehyde dehydrogenase. It is inhibiting the aldehyde dehydrogenase enzyme. So because of that, it increases the aldehyde level. It increases the acetaldehyde level. And acetaldehyde level increase, that can cause the flushing reactions. Because of these flushing reactions, the patient feels drowsy, the patient having chest discomfort, the patient is having respiratory depression. It is anti-craving agent? No, it is not anti-craving agent. In anti-craving agent, we have the other drugs like acamprosate, naltrexone. We use these drugs mainly. We also have topiramate, ondansetron, all these drugs can be used as anti-craving agent, but not this. Can be used in patient who have mild motivation? No, we need the strong motivation, because the patient is having these problems. So mostly the patient don't use these drugs. So we need the strong motivation. So it is the drug if taken with the alcohol. It should be taken with the alcohol. So mostly the effect of this drug is for around 1 to 2 days, right? So the effect for 1 to 2 days, because some students were saying ki sir the days were also given. So for 1 to 2 days the effect is there. So within 1 to 2 days, if the patient take the alcohol, it can have these problems because of the disulfiram. So always remember disulfiram like reactions or disulfiram, again very important question. Nowadays they are frequently asking. Now these are some of the match type of questions. Antimicrobial drugs with microorganism you have to match. Meropenem, metronidazole, vancomycin, ceftriaxone. So first match which are very known like metronidazole. I think everybody is aware metronidazole is for bacterioids. Bacterioids infection we use the metronidazole. Vancomycin, I think everybody is aware for MRSA. Vancomycin is drug of choice. Metronidazole is the drug of choice for bacterioids. Vancomycin is the drug of choice for MRSA. Ceftriaxone, some are saying कि penicillin were given, some are saying ceftriaxone is given. So whatever, whether it is penicillin or ceftriaxone, it is used in H influenza. H influenza, penicillin used for H influenza pneumonia, ceftriaxone used for H influenza meningitis, so they can be used. And meropenem, carbamazepines, they can be used for Klebsiella. They can be used for Klebsiella, right? That is carbapenem. So this is the match you can see. So A with the 3, B with the 4, C with the 1 and D with the 2, right? So this is the match about the microorganism. So I hope you all are aware. This is very simple question. Same the match with the antidote also, the drug with antidote. So I hope you are aware. Heparin is protamine sulfate. So the antidote, again very important question. So heparin, protamine sulfate antidote. In ethylene glycol, methanol, ethanol, in all fomepizole is the antidote. That is alcohol dehydrogenase enzyme inhibitor. In valproate, there is risk of increased serum transaminase. So there is risk of increased ammonia, right? So because of that, we use the levocarnitin. Because of that, we use the levocarnitin. So in the patients who have the valproate induced hepatotoxicity, increase the ammonia level, then we give the levocarnitin. In hydrofluoric acid, because of the electrolytes or because of the burns, we can use the calcium gluconate. So calcium gluconate can be used in hydrofluoric acid, right? So these are the antidotes matched. And next question, very important, regarding the dilution of epinephrine used in different setting. In anaphylaxis via intramuscular, we can also use via subcutaneous. So in that we use the 1:1000 solution. 1:1000 solution. If you use intravenous, then we need the more dilution. In intravenous we need the more dilution, intravenous, or we can use intraosseous also, intraosseous. So intravenous or intraosseous, then we can use in cardiac arrest, and in that we need more dilution, otherwise the patient can have the arrhythmia, right? So because of that 1:10,000, so 10 times more dilution. With lignocaine, local anesthetic, so mixed with the local anesthetic, ideally it is 1:2 lakh solution, but it can be taken as 1 lakh also. So this one is this. So with C it is 1, with B it is 2, and with A it is 3. So this is about the dilution. So intramuscular, subcutaneous, and even in the endotracheal we use the 1:1000. In intravenous or intraosseous we use 1:10,000. With lignocaine we can use 1:80,000 to 1:2 lakh solution, right? So that can be used for epinephrine. So guys, these were the questions. We have the Unacademy NEET PG test series, so you can join these test series to enhance your practice every day at 9 p.m. as well as at 8 p.m. we have the NEET PG T20 questions. So you can enjoy these free live tests in an Unacademy NEET PG section. As well as we have the plus subscription, so you can access the best of Unacademy by this plus subscription. Daily live class, structured course, live test and quiz, unlimited access to all these by one subscription only. We have the iconic subscription also. In iconic subscription you get the best of Unacademy as well as the best of Prep Ladder. So live classes, batch course and tests and quizzes from the Unacademy, as well as video lectures, question bank 2.0 and rapid revision series from the Prep Ladder. And for both you can apply my code Pharma UA or Dr. Dinesh. To get the subscription, simply download the Unacademy learning app, select the NEET PG and then select the get subscription option. In get subscription you have to select the plus or iconic, then you have to select the month and then apply the code and you will get the 10% off on the subscription. So I recommend you to take the 12-month subscription if you are preparing for next exam. So we have already started the intensive revision batch for the students who are preparing for this NEET PG exam. So today only the second batch was started for this intensive NEET PG exam. In this intensive revision batch for NEET PG I am taking the Pharmacology. So this is 1 month course. The second batch started from today only. So these are just to guide you how to use the best platform for learning, Unacademy platform. So thank you guys, let's crack it.